Well, thank you very much. Thank you for the opportunity to present. Thank you for the hospitality. And I hope that you'll get something out of the presentation. I do have slides that unfortunately use quite a bit of medical lingo, but I will try to explain them as well as I can. I also want to say that I understand that I will probably overlap quite a bit with some of, well, I guess both of the next two speakers. So I hope that there won't be that great of an overlap and you'll get something out of my presentation. It's also quite a pleasure to be here after last year's Bob Gagel. Bob Gagel is, some of you may know, was one of the fathers of the multiple endocrine neoplasia field, at least in the United States. And over the years, I know him for more than 20 years now, has been somewhat of a mentor to me in the field of multiple endocrine neoplasias. Finally, a correction on the title that you all have. When I first accepted the invitation, because I'm a geneticist, I'm a clinician, and I'm still looking for genes for patients with multiple tumors, I had asked Joe whether I could present to you our work on succinate dehydrogenase, which is sort of the newest field on multiple endocrine neoplasias. I understand that none of you has anything to do with succinate dehydrogenase mutation, so I dropped that out of my talk. So it's on the title, but it's not on the talk. I will only talk about multiple endocrine neoplasia type 1 and type 2. And so what is multiple endocrine neoplasia type 1? The term multiple endocrine neoplasia, as you know, refers to the occurrence of tumors in 2 or more endocrine glands. MEN1 is a syndrome of combinations of tumors in over 20, I mean, that's amazing, over 20 different endocrine and neuroendocrine sites, and one might say also non-endocrine sites also, although I would like to think of even the sites that are non-endocrine as potentially endocrine. For example, there are tumors in MEN1 in gastrointestinal cells. Well, those are, by nature, neuroendocrine cells. The most significant organs that are affected are the 3 Ps. And so it's easy to remember for medical students and for lay people. 3 Ps, parathyroid, pituitary, and pancreas. And if you remember these 3 Ps, you cover practically 80% or so of the manifestations of MEN1. But of course, as I said, if you want to use the medical terms, it's far more complicated than the 3 Ps. But you can see 90% of the patients have some abnormality in the parathyroids, as the previous speaker very nicely presented. Enteropancreatic tumors, and there's a variety of tumors. It's on my slides that you are all getting, so I'm not going to go through all the tumors. Pituitary tumors, particularly important. So this session is apparently about pediatrics. So I'm going to talk primarily about the parathyroid and the pituitary, because these are the 2 manifestations of MEN1 that typically present in childhood or in young adulthood. Most of the other lesions that are here, the enteropancreatic tumors, for example, or the carcinoids, present, they start in young adulthood, but typically late 20s, mid-30s. I'll show you a slide where I will have the different ages where the various manifestations present. For example, adrenocortical tumors, tumors of the adrenal glands. This is not pheochromocytomas. This is cortisol-producing tumors or non-functioning tumors for the most part that affect almost half of the patients with MEN1. Those don't become clinically significant until late in adulthood, relatively late, 30, 35, 40, although they sometimes start appearing at the age of 20 or so. Lipomas can be present early, but again, later in life, most frequently. Facial angiofibromas, that's a very important manifestation. This is not an endocrine organ. These are the blood vessels that supply the blood to the skin. And what happens is that patients with MEN1 get this very peculiar skin lesions which, however, are very, very significant for osteogenesis, and I'll show you why. So hyperparathyroidism, the high PTH levels, and it flows very nicely from your presentation, I so eloquently presented. It is the most common feature of MEN1. It occurs approximately 90% of the patients, and it generally presents between the ages of 20 and 25, and it's rare before the age of 15, but starting, it's almost like a clock. I yet have to see an MEN1 patient who is 19 or 20 who doesn't, by the time he is 19 or 20, already have high PTH and high calcium levels. Now, you heard some of the clinical manifestations, and I was talking to Dr. Azat saying, oh my gosh, I've never seen calcium around the eye. You know, this is back in the 50s, of course. You never see that by the time that you are 20. These are patients who don't have symptoms. So none of the symptoms that were presented earlier would actually be there. Yet, when you do the calcium levels, when you do the PTHs, as I said, I yet have to see an adolescent or a young adult, 18, 19, 20, with MEN1 who doesn't have a high PTH and a high intact calcium, a high intact PTH and a high ionized calcium levels in the blood. It's amazing. So it's actually a very good biochemical screening test. Severe hypercalcemia resulting in crisis or parathyroid cancer are rare, as the previous speaker said. I'm not going to go through the symptoms since you already heard them very nicely. And the treatment for hyperparathyroidism is, of course, surgery, removal of the parathyroid glands. I think this is going to be covered by one of our next speakers, so maybe I shouldn't focus too much on the surgery issue. I do want to say, however, that, and this is a very serious issue when you're dealing with adolescents and young adults where you diagnose patients with MEN1 with hyperparathyroidism, the issue of when do you do surgery is very, very important. And I don't think we should enter into a debate here because it is a very controversial issue. When do you do surgery? Generally, I don't do surgery in patients with MEN1 and hyperparathyroidism who are young who don't have symptoms. Okay? And there are specific recommendations that are listed here when one does this surgery. Serum calcium consistently above normal with symptoms, 24-hour urinary calcium over 400 milligrams, because when you have that, that's when you get the multiple kidney stones. And of course, when your creatinine is clearance is decreased, which shows that, or may mean, that your kidney function starts not being normal. And when your bone mineral density goes down, because when that happens, that's when you have an increased risk for fractures. And if your age is lower than 50, but most of the time, as I said, you don't do that surgery before the age of 18 or so. But why is one of the criteria to have a younger age? Because if you have any of these symptoms or any of these biochemical signs before the age of 50, that means that you are looking at a long life ahead of you with abnormal calcium levels, which, of course, as the previous speaker said, may have tremendous consequences for our overall health. So here's an important slide, a very important slide from one of the best groups, physicians that were actually my mentors when I was a fellow at the NIH, Dr. Marks and Dr. Spiegel. So this comes from NIH, but it's not my work. Back in 1998, they published this beautiful paper where they studied 130 patients with MEN1 during 15 years at the National Institutes of Health in the United States. And these patients were brought in as inpatients, and because these were done as research studies, they were exquisitely studied. I mean, this is a very, very good study. So this is not just simply based on reports or questionnaires. This is actual study of inpatients that stayed in the hospital for many, 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 many days. And here's the data in over 15 years. Here's the data. You can see very nicely that what I told you before, that starting about the age of 16 or 20, between 16 and 20 is when you start seeing the high PTH. So really, hyperparathyroidism in terms of diagnostics is, even though there are no symptoms, again, there are no symptoms, but it's a very good genetic if you want. It's a biochemical test, but it replaces a very expensive genetic test. A very good diagnostic test for MEN1. You can see that most of the other manifestations, for example, the enteropancreatic tumors, don't present until you are 30 or so. Insulinomas, the same thing. Prolactinomas, this is an underestimate, and I'll talk more about the pituitary tumors in a second. I think that has to do with the fact that in the late 80s, early 90s, the magnetic resonance imaging, or MRI, that we used to do for pituitary tumors was, had a much poorer quality and was not detecting pituitary tumors. I will actually show you that there is a subset of patients with MEN1 that do have pituitary tumors. And in fact, pituitary tumors, unlike hyperparathyroidism, is the tumor from all the MEN1 related tumors that presents or has the capacity of presenting much, much, much earlier in life. I actually was a fellow when I wrote up the first case of a child with pituitary tumor. I'll show you that publication in a second. So this is the annual screening that we now recommend. The hyperparathyroidism, calcium, and PTH for patients that have MEN1 annually should be screened with it's just a simple ionized calcium and intact PTH level starting the age of 8. Because, as I said, you start, this is a very, very good biochemical science. It has nothing to do with symptoms. These patients can go on with relatively elevated PTH and relatively elevated calcium for many, many years before they have any symptoms. Gastrin is not needed until after the age of 20. Fasting glucose and insulin, you can start at the age of 5, but again, clinical symptoms, and it's not necessary to do it, but for many other reasons, at least in the United States, we believe that getting a fasting glucose and insulin level after age 5 is a good screening test. Chromogranin A is a marker that we use for the other tumors. You can start getting it at the age of 20. For pituitary, prolactin and IGF-1 levels, once you have a family, and the same applies for the insulin levels, starting at the age of 5. The MRI and the CT every 3 to 5 years, but you shouldn't do it until after the age of 20. So I won't say much about the genetics, just a couple of slides, because I understand Dr. Izzat will spend some time on it. But I will go over the recommendations briefly in one slide, and then just say that I have here the fact that the pituitary tumors can actually be very early. It's not the most frequent manifestation at an early age, but it is the youngest tumor, or the youngest presenting tumor, earliest presenting tumor in MEN1. There are more than 1,300 mutations today in the MEN1, and I'm not sure whether Dr. Izzat will go over the various types of mutations, but I do want to say that that is a big complication of genetic screening for MEN1, very, very different from the case in the MEN2 gene in rat, because here the mutations can be all sorts of mutations. You don't know whether a patient that has a mutation will have the disease. Some of the mutations are what we call missense mutations. They only change one letter of the alphabet in a protein that is otherwise completely intact. And when you have something like this, which happens in about 30 to 40% of the patients with MEN1, you really don't know what it means. And it becomes even more complicated today when patients have the ability to do even whole exome sequencing, just paying themselves. I don't know how frequent that is in the UK, but in the US today, whoever has the money can go to a company and say, well, here's my DNA, sequence my whole genome, and find out what I have. And when you do something like this, you're stuck. It's just like going to an MRI suite and say, well, here I am, scan me from head to toe and find out what I have. And then you're stuck again, because there's no way anybody who's over the age of 40 that will go to an MRI suite, will do an MRI from head to toe, and will not find something. Okay? Well, guess what? When you do whole genome sequencing, we had dinner yesterday and we were talking about this. Each one of us has 120 or so genes that are completely inactivated. And if you're going to look at a gene like MEN1 that has 40% of the mutations as what we call missense, just one letter of the alphabet changed, well, guess what? Each one of us has 400 of these genes in that way. So do we have 400 diseases? No. We can talk more about this at the question session. So instead of genetic testing, I already mentioned that the biochemical screen of the calcium and the PTH in a young group is a very, 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 very good test for a patient with MEN1. Another one is this one. Now, I unfortunately did not have a kid with this, so I had an older patient, but I think it's better that I have an older patient here because in a kid it actually looks a little bit lighter or smaller. This is what I was telling you earlier as angiofibromas in patients with MEN1. I don't know how many patients here with MEN are in the audience with MEN1, but I'd be happy to look at your faces and tell you whether you have this. Presumably, and listen to this number, 75 to 85% of patients with MEN1 have this, and these lesions start appearing at the onset of puberty or right at the end of puberty. So they are hormone sensitive, particularly female hormone sensitive, estrogen sensitive. So they are not there before puberty. They start coming out peripubertally. They're almost always there, 75 to 85% at the end of puberty. And these are small, totally benign lesions of the superficial blood vessels, the blood vessels that supply the blood to the skin. They're particularly prevalent on the face, and I'm not sure we know why. But if you look around the saddle of the nose, around the upper lip, these are the places you will find them. They're easy to recognize, and given the fact that 85% of the patients have it with MEN1, you have two perfect tests to substitute for a genetic test. You have the angiofibromas, and then you have the intact PTH and ionized calcium. And if you combine the two, you have an almost better than the genetic test screening capability without spending $1,000 or so. That's what the test costs in the United States. There's another skin tumor that is not as frequent as the angiofibromas, and these are the collagenomas. Those are present in about 50 to 60% of patients with MEN1. They are also more prevalent after puberty or in older adults. Okay, so I think I discovered this, and I think Dr. Izzat will go over this too again. Generally speaking, in the United States, we do not recommend genetic testing for MEN1 in a sporadic case. You have very good screening tests, as I mentioned, that are clinical or biochemical. Now, in a family with MEN1, where you already know the mutation and the mutation causes disease, you can certainly get the testing done. And in the United States, an insurance will pay for that. But in a screening, in a genetic sporadic case, an insurance will have a hard time paying for it. Okay, so I'll switch gears and go to the MEN2 syndromes. Here, 95% of the patients have medullary thyroid cancer. The pheochromocytoma is present in about half of the patients. And hyperparathyroidism here is present in about 15 to 30% of the patients. But it's a much milder form of hyperparathyroidism than it is in MEN1. It is important to realize that MEN2 is actually not one disease. It is multiple diseases, at least 3 syndromes, the MEN2A, 2B, and familial medullary thyroid cancer. In fact, one might say that is at least 5 syndromes, which are here, because the various types of multiple endocrine neoplasia type 2 predispose to different types of tumors and also may be picked up by different clinical signs. For example, there is one type of MEN2, which actually was described by Bob Gagel, the speaker at your previous session when he was a fellow. So here's MEN2A, that was described by Bob. And this is a type of MEN2 that presents with another skin disease, which is lichen amyloidosis. And I may have a picture of it, but it's basically a white plaque that appears when you're young, typically on the upper extremities, but it can be elsewhere as well. There's another condition which is associated with multiple endocrine neoplasia type 2, and it's particularly important for kids with multiple endocrine neoplasia type 2, and that is Hirschsprung's disease. And what is that? Is a condition where you are born with an inability to have a proper bowel movement because the nerves that supply or innervate the gut, we were talking about before about how the gut is innervated and all the bowel movements we do have to be tightly controlled by our nervous system. Well, that is not there. The nervous system is not there when you have Hirschsprung's. And that's particularly interesting because what it means is that the gene that is responsible for multiple endocrine neoplasia type 2 has actually two different roles. A very different role when you're younger than it has when you're older. When you're older and you have certain mutations, you get tumors. But when you're younger, this gene, the RET oncogene, is actually very important for the development of the nerves. And that is why when you have mutations or changes in that gene when you're younger, you may get Hirschsprung's because you don't develop normally the nerves that supply the proper innervation or provide the proper innervation to the gut. That's what Hirschsprung's is, and the cause of Hirschsprung's in multiple endocrine neoplasia type 2. And then there is multiple endocrine neoplasia type 2B, which is another developmental disorder. And it's also very important for kids. I think I have seen probably the world's largest collection of patients with MEN2. I'm always stricken when I see patients with MEN2B as to how different the disease is from the rest of the patients with MEN2. These are patients that are extraordinarily tall, they are skinny, they have what we call marfanoid habitus because they look like patients with another genetic disease that has a completely different genetic etiology, Marfan syndrome. So very different, very different. And these patients, not only they are tall and they're skinny, they also have these peculiar tumors in various areas of their body, but more important for a geneticist at the bottom of their tongue and the inside of the lower lip. These are big bumps on the inside of the lower lip. So you can easily make the diagnosis. You just ask the patient, open up the mouth, stick the tongue up, and look between the tongue and the lower lip and see these bulbous masses there. These are ganglioneuromas. So if you have a patient who's tall and skinny, has some endocrine issues, and has these bumps in the mouth, that's it. It's MEN2B. MEN2A presents later in life. MEN2B is, as I said, a pediatric developmental disorder. The medullary thyroid cancer only type of MEN2 is an adult disease. Unlike MEN1, there is some good correlation here between the types of tumors you get and the types of mutations. And I'm only showing the slide for showing that these mutations that cause certain types of the disease are concentrated in different parts of the molecule. Now, far more importantly, and I understand I may overlap with some of the things that will be said both in the genetics part and the surgery part, but far more importantly than the genotype-phenotype correlation in terms of age presentation is the fact that you have different risks of the type of the tumor you get and how metastatic and how aggressive the tumor will be depending on the mutation you have. And that was very nicely presented by Bob Gagel's group in 2003 in this paper in New England Journal of Medicine. So today, and again I understand this, you're going to cover this in the surgery part? Yes, okay, so there are three groups of mutations that, and for which we have different recommendations for thyroidectomy, so I will not say much more about that at this point. But I do want to point out, and I'm not sure if Dr. Izzat will have a slide on this, the contrasts in genetic testing because of what I just told you about the recommendations for surgery for thyroid tumors in MEN2 between MEN1 and MEN2. So, and that is very important because I'm not sure how the national health system here follows these recommendations, but this is very important for us in the United States because the insurance companies know this, and they simply don't pay for certain tests if we don't follow the recommendations as they were published in JCNM in 2001. So here is the difference between MEN1. MEN1, the gene is menin. It identifies affected, yes. For the red, which is the gene for MEN2, yes. Surgery prevents cancer in MEN1? The answer is no. So very important for an insurance company. They won't pay for the MEN1 testing because this is not met. Whereas in rat testing, that is met as a criterion. So they will pay for that because of the thyroid surgery. Does treatment cure cancer in MEN1? Most of the time, no. You have to make a case if you have a carcinoid or some other tumor. So then in that case, they may pay. But in rat, does it prevent cancer? Yes. Early thyroidectomy, for those that have the mutation, that's bad. It does prevent cancer. Is menin testing recommended for a child? As I said before, in some cases, yes. When you have an early pituitary tumor, when you have a family with MEN1 where you know the mutation is pathologic, yes. But that's not always the case. It's always the case, yes, for the rat, because it prevents cancer. Chromosomes, of course, are different. The mutations are different. Let me just go to the last point here. There is a false negative rate for MEN1 that is up to 20%. What that means is that only 80% of the patients with MEN1 will have a positive test on genetics, which is why I said before when I talked about the calcium and PTH levels and the dermatologic signs, if you put the two together, you have an almost 90% sensitivity rate of detecting a patient with MEN1, whereas the genetic test is only 80% good. So here you have a much better way of detecting patients than genetics. The false negative rate, on the other hand, for the red is only about 2 to 5%. So it's a far better test there. For pediatrics, and that may be, yes?
Sorry, just a question. Are those statistics based on the US?
No,
Or is that just...
I haven't seen any more recent British stats, but this is, and especially it's true for NIH, we have patients from all over the world. So this is overall numbers from various studies. Dr. Izzat, any?
I would say that it's a little bit better, perhaps, with better testing now, but I can talk about that.
You're going to go over it.
But there is definitely, I would say, at least 10% of MEN1 we won't explain genetically at the moment. So
it's still 10%?
yes, yeah.
You're referring to deletion testing.
Yeah.
I would say 15% still. Okay. Anyway, I'm sorry?
If it's been more than 10, 15 years since the family's investigated, yes.
Yeah.
Because we've had 3 families diagnosed in that way.
I had my daughter who started testing 13 years ago when they were negative. She's experiencing a lot of symptoms.
Any test that has been done, so in the United States, any test that has been done 5 years or more from now, we repeat. Because it's about 5 years, so it's about 5 years ago, it's about 5 years ago that we started testing for deletions of chromosome 11 where the MEN1 gene is. And those are detected now. Some of the time, I wait actually for a year or two because the technology gets so much better. And when you repeat a test, unless you clinically need it right away, I actually prefer to wait because I know the technology will be even better a year or two from now. And these numbers may improve substantially. I still think in MEN1 that at the end you will end up with about 10% of the cases That's why I'm saying I'm not thinking we are quite there. I think you will end at the end with a 10% of the cases that you won't have a mutation in the MEN1 or a deletion. So yes, patients that have been tested years ago should be retested, but you have to wait if it's not absolutely clinically indicated, because technology will only get better.
Yeah, I just think if you've had a diagnostic test and they've found a gene fault, that's then known for the family, and if subsequent family tests have happened, then those results should hold true. If the first person in the family hasn't yet got a genetic diagnosis, that's the area where I said it's more than, say, 10 years. Technology has moved on a lot, and there may be...
She's only 5 years old, so right at the bottom age, isn't it? So
Right.
it might be better to do it now.
Yeah. It depends on the technology. It depends on what Dr. Izzat is using or the National Health System is paying for. In the United States, if I'm going to repeat it, I'm going to repeat it now with the best technology that's available, so that you know something that you know will not get much better in the next 2-3 years. Although it's an amazing world out there in terms of genetic testing right now. So let me finish my presentation on MEN2 in pediatrics, because I don't want to overlap too much with what the surgeons and the geneticists are going to say, with a relatively new trial for kids with metastatic medullary thyroid cancer that we are actually conducting in the United States at the NIH. Although right now we are close to new recruitments, we may open to new recruitment again next year. So I did show you before the slide where I showed the protein and what it does, the red. This slide here shows that different parts of the molecule are perfect substrates for specific medications. And the red is what we call a tyrosine kinase receptor. It's nothing else but a molecule that is involved in a very significant part of the signaling system of the cell. Just like calcium, mentioned earlier, regulates many functions of the cell. The cell has many other proteins around that regulate specific functions of the cell. So one of this class of proteins is what we call tyrosine kinase receptors. They're particularly important for growth and proliferation of cells. The red is a tyrosine kinase receptor. It regulates growth and proliferation. That's why when you have a mutation in the context of MEN2, you have tumors, because this gene becomes overactive and leads to excessive growth and proliferation. So you can block that by blocking the function of the RET using what we call a tyrosine kinase inhibitor, or in brief, TKI. So in adults with medullary thyroid cancer, about 5 or 6 years ago, there was a medication known by its initials, ZD, a number 6474, or Zactima, that seemed to work very well. It's a tyrosine, it was at the time a novel tyrosine kinase inhibitor, worked very well for adults with advanced or metastatic medullary thyroid cancer. And of the patients accrued today, this seems to lead to remission in about 30% of the cases. So we actually did do a trial of this medication, which is now commercially available under the name of vantendenib, in children and adolescents with metastatic MTC. These are kids that, for one or another reason, did not have the thyroidectomy that is recommended, because they were not diagnosed earlier, because they didn't have the genetic testing, or because they were new cases of MEN2 and they were diagnosed at the time they presented with medullary thyroid cancer. So let me show you, this is the substance. It's as again known as vantendenib now. It's a tyrosine kinase inhibitor. Here is what the responses were in adults. It's about 30% went into remission. Here is our criteria for the study. How many patients we treated in this, we have treated so far. All of them had actually one mutation, because these are typically the patients that you misdiagnose or don't diagnose until they actually present with metastatic thyroid cancer. All fairly young. 4 patients were between the ages of 5 and 12. That's unfortunately, it's a very bad disease to have when you're so young. Here is how these patients presented, the size of the tumor, where they had mets. Most of them had mets in the lymph nodes, or all of them had in the lymph nodes, but some had already, about half of them had metastasis in the liver, bones, lung, brain, and so forth. And here's what the medication did. It actually worked miraculously well in about 35% of our patients. Here is a patient who had mets in the liver, and you can see how these lesions almost melted down. Here's a patient with mets in the lung that also the lesions disappeared. And again, the same patient had mets in the liver, and they got significantly smaller in response to vantetinib. So here's a table of the 11 patients we have treated so far. On average, after about a year and a half of follow-up, both calcitonin and another marker, CEA, decreased substantially, and the size of the tumor decreased substantially in about half of the patients. So actually, the response rate for vantetinib in pediatric patients with metastatic MTC seems to be better than what it has been in adults. So here again, just another graph showing partial responses on those that had stable disease. Now, when you give a tyrosine kinase inhibitor to a child, you always have to consider effects of the tyrosine kinase inhibitor on endocrine function. As I mentioned before, these receptors that are known as tyrosine kinases, like RET, are involved in growth and proliferation of tumor cells, but obviously they're there because they control growth and proliferation of normal cells. So when you give a TKI or an inhibitor of these substances, of these receptors, you always are concerned about effects on things that grow in a child, you know, the bone, the skeleton, and other functions. And it is true that these medications have some serious side effects, although none of the effects that you see in whatever you consider classic chemotherapy in patients with cancer. So although there are some side effects in terms of growth and development, bone remodeling, and thyroid function, none of them as severe as any of the side effects that one typically considers associated with chemotherapy. The most significant, perhaps, side effect that you see almost instantly is abnormalities in thyroid function. And here is the data in our patients. All of them had to have additional thyroid or hormone replacement. In other words, we had to add to their already, to whatever they were getting already for thyroid hormone replacement. So I will finish here. I want to again thank for the opportunity to present. We'll have the opportunity to say more about the genetics and what we do at the NIH in the question session. This is our hospital. It's the largest clinical research hospital in the world. It's the only research hospital that has 257 beds or so, exclusively dedicated to research. It opened up, the old building in 1953, the new building opened up in 2004, and I think you will be very happy to know that the very first patient that was admitted to the new hospital in December of 2004 was a patient with a multiple endocrine neoplasia syndrome, and it was my patient. So very proud of that. You should be very proud of that. The NIH has a long history of treating patients with multiple endocrine neoplasias, and this is my group. We do want to mention in particular Dr. Lodish, who runs the vantetinib trial for MEN2 patients. So thank you all for having me here today.